Welcome to the Anesthesiology Journal podcast, an audio interview of study authors and editorialists.
Hello, I'm Jim Rathmill, professor of anesthesia at Harvard Medical School and chair of the Department of Anesthesiology, Perioperative, and Pain Medicine at Brigham and Women's Hospital. I'm one of the executive editors for anesthesiology, and you're listening to an anesthesiology podcast that we've designed for physicians and scientists interested in the research that appears in the journal. Today we're going to talk to the first author on an original research article and the author of an accompanying editorial that both appear in the October 2021 issue of the journal. With us today is Dr. Kirsten Kolodzy. Dr. Kolodzy is clinical professor in the Department of Anesthesia and Perioperative Care at the University of California in San Francisco, California. Dr. Kolodzy is the first author on an article that appears in the October 2021 issue of the journal, and it's titled Perioperative Normal Saline Administration and Delayed Graft Function in Patients Undergoing Kidney Transplantation, a retrospective cohort study. Dr. Kolodzy, thank you for joining us.
Hello, and thank you for the invitation to discuss our study.
We also have with us today Dr. Dhuminda Wijesundara. Dr. Wijesundara is professor in the Institute of Health Policy Management and Evaluation and endowed chair in translational anesthesiology research at St. Michael's Hospital in the Department of Anesthesiology and Pain Medicine at the University of Toronto in Toronto, Ontario, Canada. Along with Dr. Stuart McCluskey, Dr. Wijesundara authored an editorial that accompanies Dr. Kolodzy's original research article, and it also appears in the October 2021 issue of the journal titled Normal Saline for Kidney Transplantation Surgery, Less is More. Dr. Wijesundara, welcome and thank you for joining us.
Hello, and thank you very much again for the invitation. I'm really looking forward to this discussion.
Dr. Kolodzy, congratulations on the publication of your study. Let's start by setting the stage for listeners. During kidney transplantation, crystalloid solutions are often infused to maintain intravascular volume and to ensure adequate graft perfusion without the use of synthetic colloids and vasoconstrictors, which are thought to cause renal vasoconstriction and possible additional acute kidney injury. Normal saline was the first choice crystalloid for kidney transplantation over decades based on hyperkalemia or concerns about hyperkalemia with balanced potassium-containing crystalloids like lactated Ringer solution. But now numerous randomized controlled trials and one systematic review have described adverse physiologic and metabolic effects of fluid resuscitation with normal saline compared with balanced crystalloids in kidney transplant recipients. Can you walk us through those adverse physiologic and metabolic effects associated with normal saline and how they develop?
We have a good understanding on how normal saline affects electrolytes and the acid-base status these days. Normal saline contains 154 millimoles of sodium and 154 millimoles of chloride per liter, and this chloride content is about 50 millimoles higher than the serum chloride. Consequently, large amounts of normal saline administration can increase serum chloride levels or even cause hyperchloremia. High chloride levels then decrease the strong ion difference and result in a hyperchloremic metabolic acidosis. In a second step, this acidosis can then induce a shift of potassium ions from the intra to the extracellular space, and that results in increasing serum potassium levels or even hyperkalemia. And as you said, the effects have been shown in numerous randomized controlled trials in a general surgical population, but also in patients undergoing kidney transplant. A good overview is actually provided in the Cochrane Systematic Review and Meta-Analysis by Wan and colleagues from 2016. And as of today, we actually have even more randomized studies that all find similar effects on normal saline administration. That is, hyperchloremic metabolic acidosis and an increase of the serum potassium levels. Another physiologic effect of normal saline relates to kidney function. Chloride-rich fluids might have a direct effect on kidney perfusion and GFR, and high chloride levels might prolong the time to urination. This has been suggested by animal research and one volunteer study. However, the exact mechanism of the normal saline effect on kidney function is still under debate.
Okay, so the effects of normal saline administration on clinical outcomes, especially on kidney graft function, are still unclear. So your team set out to examine clinical outcomes more closely. What was the hypothesis of your study?
Well, that is correct. Even though physiologically it seems possible that normal saline affects kidney function, the clinical studies are inconclusive. We have two types of studies that report clinical outcomes of kidney function with normal saline administration. First, there are the studies that investigate metabolic changes induced by normal saline, and these studies often also report effects on kidney function, but they generally cannot find an effect. Many of these studies include not more than 60 or 80 participants overall, and we believe that these studies are just underpowered to show an effect. In this case, the lack of evidence is not evidence for the lack of effect. We also have large clinical trials and database studies, and those results seem really conflicting on the first sight, some reporting an effect and others don't. When we reviewed these studies, we noticed that patient populations of these trials were very highly variable in terms of risk for kidney injury, and that these studies also administered a wide range of normal saline volume. We also realized that we actually had access to data of a large population of kidney transplant recipients that are per se at a high risk of perioperative kidney graft injury, which we see clinically then as delayed graft function. And at the same time, many of these patients received high volumes of normal saline. We decided to study this high-risk population, and we hypothesized that the high volumes of normal saline, as compared with balanced crystalloids, increase the risk of delayed graft function in kidney transplant recipients.
So walk us through how you conducted this study, and specifically, can you review how you defined delayed graft function, and then how you divided the transplant recipients into various groups based on the crystalloid solutions they received after transplantation?
So this is a retrospective cohort study that included all adult kidney transplant patients at UCSF from 2005 to 2015. The cohort included living as well as deceased donor transplants, and we also have patients included that were not on dialysis at the time of transplant surgery. We excluded all patients that had received a combined transplant, such as combined kidney-liver transplant. The data came from two sources. The electronic anesthesia records from our institution provided all data on the anesthetic management and perioperative data, and then the Scientific Registry of Transplant Recipients, in short, the SRTR. That database provided transplant recipient files that contain variables deemed relevant for outcomes assurance. The SRTR is actually a national database funded by the government to monitor transplant centers in the United States for outcomes and to facilitate research. And as such, it is a really widely used database in transplant outcomes research. Our primary outcome was delayed graft function. It was measured as the need for dialysis within 1 week after transplant surgery. This is a very common definition of delayed graft function in transplant research. Our primary exposure variable was the percentage of normal saline on the total amount of crystalloids given. We choose this variable because we realized that many of our patients actually received a combination of normal saline and balanced crystalloids, and the ratio of both fluids is at our institution only at the discretion of the anesthesia provider. This is in contrast to the total amount of crystalloids that is often influenced by external factors such as blood pressure, blood loss, duration of surgery, or patient comorbidities. So we thought that this exposure variable, the percentage of normal saline on the total amount of crystalloids, might be a little bit more random and less prone to confounding. We defined 3 exposure groups. We had patients who received 30% or less normal saline, and we call this group the low normal saline group. Patients who received more than 30% but less than 80% normal saline is called the intermediate normal saline group, and patients who received 80% or more normal saline is the high normal saline group. We reported the incidence of delayed graft function per normal saline group, and we also conducted an adjusted analysis where we included potential confounders and covariates into the analysis model. Adjustment variables were the year of transplantation, the total volume of crystalloid solution, duration of the surgery, the need for vasopressor infusions, the need for red blood cell transfusions, the recipient's sex, age, BMI, race, and dialysis vintage, the number of human leukocyte antigen mismatches, and then donor characteristics such as donor type, donor age, and donor sex.
So a pretty terrific look back at over 2,500 kidney transplant recipients using a pretty robust combination of databases. What did you find?
So in our study, the incidence of delayed graft function was almost 16% in the low normal saline group. It was 17.5% in the intermediate normal saline group and 21% in the high normal saline group. In our adjusted analysis, we found that the odds of delayed graft function was significantly increased by 55% for the high as compared with the low normal saline group. Some might wonder why the overall incidence of delayed graft function was only 19% in our cohort, which seems to be low compared to other reports. But remember that this was a mixed cohort of deceased and living donor transplant recipients, with about 40% living donor recipients. Those have generally a much lower risk of delayed graft function because the donor organs are very healthy and cold ischemia time is generally very short. So when we then looked at deceased donor transplants separately, we found that the incidence of delayed graft function was 24% in the low normal saline group, almost 29% in the intermediate group, and 31% in the high normal saline group. And in adjusted analysis, the odds of delayed graft function increased significantly by 52% for the high as compared with the low normal saline group. When we look at living donor recipients only, the incidence of delayed graft function was much lower at baseline, as expected, and it increased from 4.4 to 4.7 and 5.8% for the low, intermediate, and high normal saline group. But the adjusted analysis for this subgroup did not show a significant association between exposure groups and delayed graft function.
Well, what do you conclude from your study?
So we found that a high percentage of normal saline administration on the total amount of crystalloids given perioperatively is associated with delayed graft function in kidney transplant recipients. This is a retrospective study, and it really has limitations. We can certainly not establish any causal effect here. However, when we consider the context of already existing evidence, we believe that our study is in line with the hypothesis that with increasing amounts of normal saline and increasing vulnerability of the kidney, normal saline might have a negative effect on kidney function.
What were the limitations of your study?
Our study does have limitations, that's correct. First of all, our electronic anesthesia records collect clinical data, and there's really no validation process in place. We can therefore not be sure that the data we used are 100% correct. One example here is that we had about 220 records with no crystalloids charted. And for most of these records, we just have to assume that this is a charting error. But we also assume that data entry errors affect all exposure groups at the same extent, and therefore it should not affect differences in outcome between study groups. Another common limitation of database studies is that we only can use the data that are actually collected in the underlying databases. In our study, we could not include data on all comorbidities, data on laboratory values, and our study period ended with discharge from the recovery room, ignoring the treatment that followed on the floor. For example, we only investigated the one outcome, delayed graft function, that was defined as the need for dialysis within 1 week after transplant. This definition has limitations because criteria for the initiation of dialysis might vary among providers and especially also among different centers. So ideally, we had included an alternative outcome, such as creatinine decline after transplant, to validate our results, but our data set just did not include complete data on any alternative outcome. And then in living donor transplants, the incidence of delayed graft function is 6 times lower as compared with deceased donor transplants. We had talked about that earlier. And also the absolute difference in outcome between exposure groups is much smaller in living donor recipients. That basically means that for our study, we did not have enough power to find a statistically significant effect in the subgroup of living donor transplants. Therefore, the results for this subgroup must be interpreted with caution. And finally, the perioperative fluid management strategies might be very different in other centers nationally and internationally. The generalizability of our single center findings might therefore be limited.
Dr. Vijay Sundara, I want to turn to your editorial that also appears in the October 2020 issue of the journal. The editorial is titled, Normal Saline for Kidney Transplantation Surgery, Less is More. You do a terrific job of putting Dr. Koladzi's article into perspective. Can you start by outlining the magnitude of the problem? How often does delayed graft function occur after kidney transplantation, and what are the long-term implications?
Thank you, Jim, and thank you very much for the kind remarks about our editorial, which was co-authored by myself and Dr. McCluskey in Toronto. So, the way I sort of conceptualize delayed graft function is, in many ways, it's severe acute kidney injury within the context of kidney transplantation. And it's multifactorial in etiology. So, the hypotheses mechanisms include hemodynamic instability, both low and high blood pressures, hypovolemia, ischemia, reperfusion injury, and certainly acute immunologic injury. The incidence depends in many ways on how it's defined. Dr. Kolodzi alluded to that already, and also the characteristics, some important characteristics of both donors as well as recipients. So when we're talking about cadaveric kidney transplantation, so a deceased donor, giving a kidney to a standard kidney using usual criteria, certainly contemporary national data in the United States suggests that about 25 to 30% of recipients suffer delayed graft function, as it's typically defined, as it's done in this study, as a need for dialysis within a week after transplantation. The two major centers in Toronto where I practice, which don't contribute data to that registry, our DGF rates are about the same, so they're in the range of about 30 to 40%. And those risks go up when you're dealing with, for example, donation after cardiac death, when you have kidney donors based on those criteria, or extended criteria donors. Why does it matter? Well, it certainly matters in terms of acute hospital resource requirements. So these patients require a longer hospital stay because of the need for dialysis. There's a longer length of stay, so there's obvious cost implications and resource implications. But probably more importantly, over the long term, there are consistent data showing that patients who suffer delayed graft function have an accelerated course of decline in graft function, so they're more likely to subsequently have graft failure and require kidney transplantation again, or transition back to hemodialysis. And so if you take the context that we don't have many organs available for kidney transplantation, we have a lot more people who require kidney transplantation, anything that we can do that can extend the life of transplanted kidneys is a good thing. And to that end, decreasing the risk of delayed graft function should be an important goal for perioperative care.
Dr. Kolodzi and her group found that the administration of high proportions of normal saline, or more than 80% of crystalloid volume, in the operating room and post-anesthesia care unit was associated with a 55% increase odds of delayed graft function. What are the strengths and limitations of the study?
So Dr. Kolodzi went through a range of the strengths and limitations, so some of these maybe seem repetitive, but I think a key thing is, although this was not a randomized trial, this was a very large observational study. There was about 2,500 participants, and more importantly, from the perspective of a study that employed multivariable risk adjustment, there were almost 485 outcome events, which means that the regression models that were applied to conduct risk adjustment here were robust and valid. The other, I think, important strength of this study, and I think that should highlight some approaches for future research, is that they really used a unique data set. They were able to link their in-hospital electronic medical records, including anesthesia records, to this nationwide transplant registry. And I think that linkage and leveraging that linkage really points to a unique opportunity to conduct research, not just in the association between crystalloid type and delayed graft function, but I think a number of other important questions in the future related to the relationship between anesthesia management and transplant outcomes. So I think those are important strengths of this study. All studies have limitations, and I think the limitations here, they exist, as with any observational study and actually any research study, but I think by no means discount the strength of the findings that they have. I think I'll touch on a few. While the study is large, the data do come from a single center at UCSF, so one can bring up the issue about generalizability, so to what extent do the findings here apply to the relationship between anesthesia management and outcomes at other centers, which may have unmeasured differences in care in the operating room, unmeasured differences in patient characteristics? That's certainly a theoretical problem. It's also a study that was conducted over a relatively long period, so from about 2005 to 2015, and certainly the risk adjustment models accounted for a year of surgery when they considered the adjusted relationship between crystalloid type and risks of delayed graft function. But what was also recognized in the study is that there was a very strong relationship between the year of surgery and the proportion of crystalloid administered. So you're much more likely to have had high proportions of normal saline administered during the early part of the study as opposed to the latter part of the study. And needless to say, there may be other important unmeasured changes in transplant care that could have occurred over this time frame, changes in anti-rejection medication choices, for example. So that's an important unmeasured difference between the arms based, which are characterized by the exposure, which is proportion of normal saline administered, which could have potentially impacted on the results. And probably the last thing, if I were to say, was that while Dr. Colozzi explained quite clearly why they used the proportion of normal saline as the exposure of interest, but importantly, when they modified in sensitivity analysis the exposure definition to the volume of normal saline, which could have been impacted by other factors, but in some ways also reflected maybe the dose-response toxicity relationship you might expect, that the higher the volume of normal saline that you administer, that risk should increase. And in that particular sensitivity analysis, the association was not statistically significant. That being said, if you looked at the point estimate, it still was in line with the primary results, so I don't think that discounts the overall findings. Overall, I'd say, as with any study, it has limitations, but even acknowledging those limitations, they do not negate the strength of the findings and overall conclusions.
Well, in your editorial, you ask an interesting question. You ask, should we conclude that normal saline has significant risks with respect to delayed graft function following kidney transplantation? I'd love for you to talk us through how you approached answering that question, and then tell us what you think. Should anesthesiologists avoid normal saline during kidney transplantation today?
I think it's a great question, and I think if you ask the question, is normal saline definitely harmful? And the answer, I think, at present is perhaps. There are, as Dr. Colozzi alluded to, there are important physiological adverse events that have been demonstrated consistently in the literature, and certainly a suggestion of a difference in clinical outcomes when high proportions of normal saline are administered. But all those data showing a relationship between normal saline proportion or volume and adverse outcomes have limitations. I guess the way I'd sort of flip it around and say is, what are the compelling reasons to use normal saline as your initial choice of crystalloid solution for kidney transplantation? And certainly when I started training in anesthesiology around 2000 or so, that was the standard approach that most of my mentors and teachers in the operating room would tell me. For this is a kidney transplant procedure, we start off with normal saline. And survey results certainly at that time show this